Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Narjust Florez and Dr. Paolo Tarantino, both from the Dana-Farber Cancer Institute in Boston, and Dr. Aakash Desai from O'Neal Comprehensive Cancer Center at the University of Alabama in Birmingham. They will be discussing HER3, an exciting new target under investigation for the treatment of multiple solid tumors. Topics they will be discussing include the rationale behind HER3 as a therapeutic target, data with HER3-targeted agents in lung and breast cancers, and their thoughts on sequencing and managing treatment with HER3-targeted antibody drug conjugates in the clinic. This episode is part of a larger educational program titled Unlocking the Power of Novel HER3 Targeting Agents in NSCLC and Breast Cancer, Expert Insights and Considerations for Precision Care. For more information on the complete program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hello everyone, my name is Dr. Narjust Florez. I'm a thoracic medical oncologist at Dana-Farber, and I'm delighted to be here with two amazing colleagues to discuss HER3 and HER3-directed therapies.
Hi, everyone. I'm Aakash Desai. I'm a thoracic and phase 1 medical oncologist at the O'Neal Cancer Center at University of Alabama in Birmingham, and really excited to join these two folks here.
Hey everyone, I'm Paolo Tarantino, breast medical oncologist from Dana-Farber Cancer Institute, and I'm also extremely excited to join this podcast talking about HER3 and the way we're targeting HER3 in these days with novel drugs.
Something I can say is that you may have listened to a lot of podcasts, but a podcast in which each member knows each other, knows each other's research, and is ready to discuss the science is unique to this one. So, Aakash, we're addressing you by first name because you're my friend, and I just introduced you by your formal name. What is HER3 and what is the biology? How do I eat this? Do I eat this with bread, pasta? How this works?
Right. So, it's very exciting in the sense that, we've all heard about HER2, especially in the context of breast cancer earlier and now with other cancers. And, this is a new molecule when we hear for the first time, sort of often confused with the HER2. But HER3 is a unique member of the HER or HER family. It includes the more well-known EGFR, which is, typically HER1, and then HER2. In contrast to these two, which are well established in carcinogenesis, HER3 is little known, but it has a limited kinase activity and drives oncogenic signaling through heterodimerization, with other HER family members. The mutations landscape in HER3 is quite rare, but we do see overexpression and amplification across multiple tumor types, including breast and lung cancer, which we'll be discussing today. And this overexpression and amplification seems to be associated with metastatic potential and decreased survival in patients with these cancers of HER3 overexpression. With that said, across these multiple tumor types, we do know that there's an increasing role of different types of HER3 targeted molecules like monoclonal antibodies, bispecifics, and antibody drug conjugates, which I think has been the most exciting space in lung and breast and other cancers these days. I think, there's increasing data on a role of HER3 in acquired resistance to non-small cell lung cancer, which is EGFR driven. Narjust, what has your experience been and how do you read the data that's coming out on this?
Well, I think for HER3, it's a new kid in the block. And we know that there are several resistant mechanisms, and we're going to be focusing a lot in EGFR non-small cell lung cancer because that's where we have more data. But HER3 is present in approximately 83% of non-small cell lung cancers. It is a common finding, but we're still learning about the biology of HER3. We know it's related to metastatic development, as you mentioned, and as a resistant mechanism for EGFR therapies. HER3 tends to be highly expressed in EGFR and HER2. These are like a family, right? They're related. They're kind of cousins, if you want to say that. And we know that certain escape mechanisms could be related to your cousin, right? Could be related to the pathway that you may have a common sense to that. It is a common resistant mechanism in EGFR mutant non-small cell lung cancers as an alternative pathway, but it's still under development as a resistant mechanism. And we're going to talk about that a little bit more because some of the data with HER3 ADCs is showing that does the HER3 expression means anything? And my question to you, Aakash, is how are these HER3 ADCs being developed in phase 1? What is the new things happening in the phase 1 space as a phase 1 trialist?
I think the antibody drug conjugates or the ADCs, are very exciting development in the field of oncology. Just a little bit of background for our audience. Antibody drug conjugates mainly have three main components: an antibody, which is targeted against a tumor-associated antigen. There's a linker, and then the linker has a cytotoxic payload, which is really the sort of old school chemotherapy, if you will, that is attached with this antibody for the drug. And I think traditionally with the mechanism, it would make sense that if we have an antigen which is highly expressed on cancer cells, and if we have an antibody that's targeting those antigens and bringing the payload inside the cancer cell, that it would work well. And to your question, Narjust, that's why we are interested in figuring out whether there is a high expression of HER3. Does that mean that the ADCs are going to work better compared to the tumors which have low expression? And I think this story has sort of been a little different than what we thought. I mean, we thought that high expression means high response, and Paolo will point out we've seen that in breast this may not be completely true. And I think even in the lung and the data that has come out recently, we're seeing that this may not be truly related to response based on how much HER3 expression you have on the cancer cells. Now, just for our audience, I mean, the HER3 expression is usually, when we talk about HER3 expression, that's usually measured with immunohistochemistry, which uses a monoclonal antibody on the frozen samples. And that's the staining method that we use even for translational purposes and sometimes for selected biomarker studies and clinical trials. Now, for HER3, the expression is usually membranous, and that means that it may be most clinically relevant since this is expressed on the membrane of the cancer cells and that we have the ADC entering through the receptor. But then in the literature, there's also some demonstration that there may be some cytoplasmic staining as well. Now, regardless, with these ADCs being developed, most of them sort of measure this, what we call as a membrane H score, which is sort of a score in immunohistochemistry, a semi-quantitative method really trying to assess the intensity and the proportion of cells that are stained with a particular protein of interest. But as I mentioned, I think, we are finding more and more about how does this translate to responses. Paolo, I know, there's a lot of data on breast, HER2 low, HER2 positive. How do you compare and contrast these ADCs, and what are your thoughts on this expression and whether there's any relation to the response?
Yes, I think in the HER3 space, we had at least two major surprises in breast oncology. The first one was that since HER3 is definitely implicated in resistance to endocrine treatment, anti-HER2 treatments, we were expecting that targeting HER3 with antibodies like lamretuzumab, patritumab, seribantumab would lead to anti-cancer responses. And instead, in most of the trials, the phase 1 trials that tested naked anti-HER3 antibodies, we really did not see satisfactory responses or PFS. And so that led to trying to target HER3 in a different way, such as ADCs, and so delivering chemotherapy through ADCs. And this was definitely more satisfactory with patritumab deruxtecan. Several phase 1 and phase 2 trials at different doses have achieved around 30 to 40% response rate and PFS ranging between 5 to 8 months, up to even 11 months in a small subset of patients with HER2 positive breast cancer. But as you were mentioning, the second big surprise was that the activity of patritumab deruxtecan did not seem to be related to HER3 membranous expression in neither of these trials, neither in the phase 1 trial that was recently published on JCO by Krop and colleagues, nor in the phase 2 Icarus Breast 01 trial, neither in the BRE354. In general, we really did not see what we were expecting. And I think this calls to the different mechanism of action of these ADCs, because we know that there is a targeted mechanism of action that refers to binding to the antibody, internalization, precise delivery of the payload. But we also know that some part of the payload of the ADC can shed in the circulation and act as simple chemotherapy, which makes it more effective against heterogeneous tumors. I think day by day, we are learning about the way these ADCs work. And I think one major question that we all have in our minds is, how are we going to sequence these ADCs now that they're becoming available more and more to treat different cancers? For instance, T-DXd was recently approved for lung cancer as well as breast and many other cancers. Narjust, how do you feel about sequencing different ADCs? Do you feel there is a role right now or in the future? What could be the challenges in this field?
When we're talking about sequencing, because the thing with lung cancer compared to prostate and breast is that we are the new kids in the block learning about ADCs. And every time I put a patient in HER2, I call my breast cancer colleague more than I can my lung cancer colleagues, because they have given this therapy for 10 years. I think for us, these ADCs are being very molecularly driven, right? So trastuzumab deruxtecan is HER2, but I believe that for HER2, in which there is no TKI oral, is probably a good move to first line, because we know that chemotherapy is still going to be there. We know the limited response with chemotherapy, and we know the prolonged response with ADCs. And my always fear in lung cancer is that 30%, approximately, regardless of mutation, regardless of outcome, 30% of patients with lung cancer are unlikely to go on a second-line therapy. For us in lung cancer, it's very key to start with the first drug first, because we lose 30% of those patients. I think when oral TKIs are exhausted, highly likely these ADCs are going to come in. And for the ones that are no oral TKI, eventually they're going to move to first line, because we're seeing that with Destiny and trastuzumab deruxtecan, in which the first line trial that I'm enrolling patients into it is moving. And even with patients don't get randomized to the ADCs, they're like, oh, chemo. And also it's the bias that we all like the best. I know we're talking about HER3, but I wanted to talk, Aakash, about another emerging biomarker quickly with the energy tumors, these other ADC that's under development. And I'm going to call it cenocutuzumab. So Aakash, what is the early data about this other drug?
I completely agree with you. And I guess like one other thing to point out, as Paolo mentioned, I think sequencing, but also I'm seeing that there's some data coming out at ESMO in bladder cancer where they're even combining two different ADCs. So it's really going to be interesting to see how, this sort of field evolves. Now, going back to your point, Narjust, there are other bispecific antibodies which have also, sort of been evolving in this space. The most promising one, I think, as you mentioned, is the zenocutuzumab, which is the HER2 and HER3-directed that inhibits sort of the HER3-dependent tumor growth, which is through the inhibition of the ligand as well. It recruits natural killer cells into the tumor bed. And there is, as you mentioned, there is clinical activity in this patient population with NRG1 fusion positive solid tumors. I think from the study that has been published about 71 patients that were enrolled pan-tumor, there was a good overall response rate, about 34%, with really promising responses in non-small cell at 35% and pancreas at 39%, as well as some responses seen in breast cancer and cholangiocarcinoma. I think this is also a very exciting space from a bispecific standpoint. I think there's more data coming at ESMO for this particular drug, both in non-small cell and pancreatic ductal carcinoma. So I think it'll be really interesting to see where this goes, and moves forward. But sort of also coming back to the ADC, and I think the most exciting in this space right now is the patritumab deruxtecan, as you mentioned, Paolo. Tell us a little bit about, the construct and how it has really been impactful, at least, in the ER positive, hormone positive, and triple negative breast cancer setting. And what's the data there, which kind of excites you there?
Basically, patritumab deruxtecan is very similar in structure to the more familiar T-DXd. So basically, it's an HER3 antibody linked through a tetrapeptide linker to DXd, which is a topoisomerase inhibitors. And what we call the drug-to-antibody ratio, so the number of molecules of chemotherapy bound to each antibody, is about 8 molecules per each antibody. So a highly potent agent. and it's being tested across breast cancer subtypes. And in general, the subtype that has been tested the most is hormone receptor positive, HER2 negative. And we saw both in the phase 1 trial, but also in the subsequent phase 2, BRE-354, and also the Icarus breast or 1 trial, about a 30% response rate in patients that were highly pretreated. So very interesting. It is a setting where you would expect very low response rate with traditional chemotherapy. And in terms of toxicities, what we have observed, it's kind of similar to T-DXd in a certain way, because we still see some chemo-related side effects like nausea, fatigue, alopecia. Interestingly, much less interstitial lung disease that one observed with trastuzumab deruxtecan. And in the phase 1 trial, a peculiar side effect that was observed was thrombocytopenia that has been observed even with naked HER3 antibodies. It may be a target-related toxicity, but we still, I guess, we need to collect more data about this. In triple-negative breast cancer, which is a more aggressive subtype of breast cancer, we saw about 20 to 25% response rate. And in HER2 positive, interestingly, up to 43% response rate. Very intriguing. And in general, we still don't have phase 3 data, but instead in the lung world, there is a phase 3 trial that is currently ongoing. I would love to hear from Narjust something about the ERTINA program. What is going on in lung cancer with the ERTINA lung or 1 or 2 trials?
So let me give our listeners a rundown for HER3 Lung 1. So HER3 Lung 1 was presented in Singapore at the World Conference on Lung Cancer over a month ago. So this is a phase 2 trial that included 225 patients. These patients had disease progression after platinum-based therapy and their EGFR positive non-small cell lung cancer classical mutations. These are the patients that were allowed in this trial, previous platinum therapy. But something that also brings my attention is that inactive and previously treated CNS metastases that were asymptomatic were allowed. The initially HER3 Lung 1 was 5.6 milligram per kilogram arm and then a titration arm. But when the data from the phase 1 came out, the titration arm was closed. These patients were heavily pretreated. They had a median number of lines of therapy around 3. Potentially a TKI for EGFR and platinum-based therapy. The primary endpoint for HER3 Lung 1 was overall response rate. And they tried to classify patients that got third-generation TKI and patients that didn't get a third-generation TKI, because third-generation TKIs are now available globally, but the numbers were no different. I'm just going to give you the numbers all combined, because they're exactly the same numbers. The overall response rate was 29.8%, and the duration of response was 6.4 months. This is after platinum-based therapy for patritumab and EGFR positive. The progression-free survival was 5.5 months, and the overall survival was 11.9 months. But something that's very important that I noticed in this trial is that 30 patients with brain metastasis that didn't have previous radiation were evaluated for CNS response. And patients with EGFR non-small cell lung cancer, CNS metastasis, lectomeningeal disease is a big issue. These patients most likely will come with this, and then we affect significant morbidity and mortality. HER3 Lung 1, they set up that overall response rate in the brain of 33.3% with disease control rate of 76%. And I think that's what I really take home is that this drug has an intracranial response. And when we talk about biomarker in HER3 Lung 1, there was no difference. So there has what Aakash mentioned about tumor membrane HER3 score or H score. And they tried to determine if this H score that goes from 0 to 300, if there was any difference. And there was no difference when it comes to the expression of the HER3 and the membrane when it comes to partial response, complete response, or intracranial response. So HER3 1 showed that patritumab, HER3 ADC, is here to be explored further. We have intracranial response, we have overall response rate, and we have a decent duration of response in patients with a median third line of therapy. I was very pleased to see this. Nothing new in safety. ILD tends to be a little bit an issue for us more than in breast cancer. The ILD rate was around 5.3%, and the bone marrow suppression effects were transitory, but they were present, and these are the ones that you mentioned, Paula.
I think what's really interesting to me, we talked a little bit about how HER3 expression doesn't really correlate with response, which I think from a mechanistic standpoint, I would like to see, that we're doing a better job at finding these patients who will respond well to these drugs. But I think from this particular setting, Narjust, in terms of the ones who have, experienced progression on osimertinib for their EGFR mutated non-small cell lung cancer, I know that guideline and the standard of care would be to try to identify what the resistance mechanisms are, whether it's sort of on-target resistance or a bypass track with MET, ALK, or other oncogene-driven tumors. But I know that there's about 40 to 50% of patients where we're not able to identify the resistance mechanism. And I almost think that it's great that we have this drug now, hopefully, once it goes and shows some benefit in phase 3, it's approved, that we can actually use sort of a, like agnostic approach in the sense that resistance agnostic approach, when we're not able to find resistance mechanisms, I think this offers a unique and really great option for our patients. What are your thoughts on that in this space?
I think that's very important because other ADCs have required a molecular target. And that, reduces the chances of patients going into an auction. But I think it's good and bad. It's bad because we are using a drug for a mechanism that we don't fully understand. And we need to understand that. And I think biomarkers still continue to be a second thought in trials, right? What is the conclusions for most of these new drugs? We need to develop more specific biomarkers, right? That's what it really, in the study with immunotherapy, right? We know PD-L1 is like, or a marker. So it's good that it can be used in patients that have EGFR-related resistance, EGFR no-related resistance, like MET amplifications, and the group of patients that we don't know. But I think we'd be very cautious too that we cannot forget biomarkers, particularly should we look for HER3 expression or should we look for HER3 mutations, right? Genomic alterations. How is the importance of developing that? And I don't know, Paolo, if you have more information in breast cancer, because we are like the Backstreet Boys. We're a little bit behind. You're like BTS. You're a little bit more out there in the future. And I'm comparing myself to the Backstreet Boys. This is a moment in my career I waited for. But what are your thoughts about biomarkers for HER3 when it comes to breast cancer?
Yeah, I would like in breast oncology to have a hit, like I want it my way, like something that works perfectly. But still, even in breast oncology, we did not find the perfect biomarker for this drug. And for most of ADCs, like even T-DXd, it's currently approved for HER2-positive breast cancer, HER2-low breast cancer. And then the colleagues from Gustave Roussy in France have shown in the DAISY trial that T-DXd has got some activity even in HER2-0 breast cancer. So we're very confused. And the same colleagues at Gustave Roussy, they also ran a trial, the Icarus breast with patritumab deruxtecan, looking at potential predictors of activity. They looked at CTCs, and there was some correlation, but not statistically significant. So the HER3-positive CTC did not predict really the activity of patritumab deruxtecan. Then they looked at the genomic profile of the disease, and they found that patritumab deruxtecan worked irrespective of the genomic profile. I really think that we're not there yet. We haven't found the biomarker yet, which is in a certain way good news because it means it can be effective across patients, across diseases. At the same time, we know that these agents also have got their toxicities, and so we would like to utilize them better, especially now that we are taking them to the early stage setting. For instance, in breast cancer, there is a randomized phase 2 trial now ongoing, designed by the SALTI Spanish Confederation group. And it's very interesting because it compares neoadjuvant patritumab deruxtecan compared with traditional chemotherapy. And it also has an arm that combines patritumab deruxtecan to endocrine treatment. And I think potentially there may be a role for ADCs in the early stage setting to actually cure patients with breast cancer. But we also know that we have to be extremely careful with the toxicities in this setting. And so it will be extremely important to develop biomarkers of activity. was previously mentioning some surprises that we had with these ADCs. And I think a major surprise we had, that is a positive surprise, was the intracranial activity. You mentioned some intracranial activity with patritumab in lung cancer, and we saw the same in breast cancer in general with ADCs. And this is very intriguing because ADCs are expected to be large molecules, not penetrating the blood-brain barrier so well. And still, with T-DM1, we used to see more than 20% response rate in patients with brain metastasis in HER2-positive breast cancer. And with TDXD and now patritumab deruxtecan, we start to see responses in relevant response rate in patients with brain metastasis. And I think we're still figuring out what is the mechanism of intracranial activity, if it's a disrupted blood-brain barrier that allows the movement of ADCs to the brain, or if it's a slow release of chemo in the circulation that allows this activity. And I think we're starting just now to learn how these ADCs work, and probably it will take several years to fully understand it. But in general, it's good news to see all of these patients with brain metastases deriving benefit from ADCs in general. And I think one other interesting thing is that beyond ADCs, we are discovering that we can also reactivate the immune system to treat cancer. Immunotherapy is a big, let's say, theme across cancer types in lung cancer, breast cancer. And what I would love to ask Aakash, if there could be potential synergy between ADCs and immunotherapy, and what is going on in the development of these two treatment modalities.
Absolutely. And I think, as you mentioned, how in breast, we're moving some of these ADCs into the earlier stage setting with neoadjuvant and other studies. I think in lung, we're seeing that we're trying to move these from second line or later therapies to, at least, even first line metastatic. Obviously, we know for lung, immunotherapy and chemoimmunotherapy really standard of care for non-oncogene driven non-small cell lung cancer. And within these subsets, when we're trying to introduce ADCs, it's really in combination with chemotherapy or chemoimmunotherapy. So actually, 2 drugs so far have really been able to have trials and data where we see that these combinations may be safe and potentially could be sort of a forward-thinking standard of care. With the Trop-2 targeted ADC, the Dato-DXd, we've seen some data on how it combines with platinum chemotherapy and pembrolizumab. And, so far we do see that, the doublet, which is basically the ADC and immunotherapy, is better tolerated, has lesser toxicity. But again, I think we're too early to say that we should forego platinum-based chemotherapy, which has been the standard and is really efficacious in non-small cell lung cancer. But I think there is some data and emerging data that this combination approach may be safe potentially. We obviously do need to have a good hold on how we treat some of these toxicities, especially as Narjust mentioned in lung. ILD is a major concern with ADCs, potentially with the lung, being the tumor of origin. So with regards to the combination of ADCs, we've also seen some data emerging on the CEACAM5 ADC, which is the tusametamab riftansin, also with the Carmen LC05 study, which combined this ADC with pembro and also had an arm which had combination of pembrolizumab, platinum, and this ADC. Again, showing that this approach can be effective. I think within the subsets, we also saw similar things in terms of patients with tumors having PD-L1 more than 50% more responsive to these combinations with ADCs, as we see with immunotherapy. But again, there's a lot to learn in this space because this is all just emerging data from phase 1, phase 2 studies early on. But I think, as we look forward and getting these ADC molecules in the clinic, with lung, obviously we have the TDXD, which is approved, potentially others that are coming in. I think it would be interesting that, we need to make sure that as these come to market, that we know how to treat some of these side effects or be aware of these side effects, and particularly ILD and others. Narjust, I know you mentioned some of the data that came out of the HER3 program with regards to that. And how do you advise practically, for oncologists when these drugs, more and more increasingly come to market and in practice for lung, what are the things to watch out for?
Before I do that, I just want to provide our listeners about an update of HER3-2, which is the follow-up to the HER3-1 data I just discussed. So HER3-2 may be in your clinic. It may be closer to you or available. So HER3-Lung2 is patritumab in patients with EGFR positive non-small cell lung cancer. But there's a big difference between HER3-Lung1 and Lung2 is that this is moving to the second-line therapy. These are comparing the patritumab versus platinum-based therapy. HER3-1 was after platinum. This is right before. And it's a global study, 560 patients. They recruited the first patient in August of 2022. And it's expected that we will see at least some preliminary data. This is from clinicaltrials.gov in 2024. But another difference about this is that the patients must have progressed in a third generation TKI, meaning osimertinib, for this HER3 ADC. Very different to the HER3-Lung1 study in which you could have progressed in first and second generation. So that means not every patient is going to be able to qualify for this because third generation TKIs are not widely available globally. And you can see that with the recruitment sites for this trial is mostly recruited in West Europe, the United States, and Asia. HER3-2 phase 3 is moving the HER3 ADC to second-line therapy after a third-generation TKI. The primary endpoint changes for overall response rate to progression-free survival, and we are hoping to see some of this. But something I want to mention about HER3-Lung2 is that science is moving so fast. So HER3-Lung2 is not allowing patients to get chemotherapy, even if they had it in combination with osimertinib. The question is, FLAURA2, right? FLAURA2 was also presented. So patients could not have any chemo prior to going to HER3-2 lung. And to follow up on your question, because the phase 3 is open, we're going to have data soon, what to do with ADCs. I treat a lot of women, and because of that, I have a lot of patients with HER2. And my mentor is a breast cancer doctor, so I guess I'm more familiar. My first thing would be to acknowledge this is a different class of drugs. Not try to compare the monitoring and the side effects with chemo or immunotherapy. These are different types of drugs. This is a targeted therapy that marry a chemo and marry an antibody. So the adverse events can last a very long time, and you're not going to have that rapid response to steroids that you get with immune checkpoint inhibitors. You have a patient immune checkpoint inhibitor, you give them steroids, and it's like the Lazarus effect. That doesn't happen a lot with ADCs. And second, ILD. Interstitial lung disease, you have to be on the look for it because it can be very debilitating to patients. So those are my recommendations. And I'm going to move it to Paolo to see what his recommendations are, and then you guys can take it from that.
I think you perfectly outlined that. I think the key recommendation there is remembering that there is at least a portion of chemo in this agent. Remembering everything that we know about chemo, meaning that if there is a high rate of nausea, such as the one that we see in most of these trials, it's important to utilize prophylactic antiemetic treatment. And for instance, with most of these drugs, we use at least 2 drugs prophylactic regimen, sometimes even 3 drugs regimens. There was recently a small randomized trial in Japan comparing 2 or 3 drug antiemetic regimens for T-DXd, showing that 3 drug regimen can really decrease the rate of nausea and vomiting. So that's the first thing, of course. Then adapting the dose. For instance, I found it very interesting, some randomized trials in the lung space, in the colorectal space with T-DXd, finding that lower dose can have the same activity, but less ILD, less side effects. I feel that finding the right dose is extremely important. And then, of course, ILD. Recently, we came out with this 5S. There is kind of 5 simple rules to remember what to do about ILD. And the first S is for screen. Understand what patient you have in front of you, what are the comorbidities, what are the prior experiences with treatment, if there is prior experience of ILD, for instance, and in general, adapting the monitoring strategy to the type of patient. The second S is scan. It's fundamental, very important to perform CT scans of the chest every 6 to 12 weeks. And of course, this is dependent on the type of patient, but also on the setting, because every 6 weeks may be potentially feasible in some centers, in some settings, but not everywhere. But I think the maximum would be every 12 weeks because we got to be careful about the side effect. And then there is, of course, synergy because we need a multidisciplinary discussion whenever there is suspicion of ILD with the radiologists, pulmonology, and pulmonologists and the rest of the team. Tension of the treatment is the 4S. Whenever you suspect an ILD with one of these drugs, one of these ADCs, stopping the treatment with the ADC. And finally, steroids. That is the mainstay of treatment. And so treating this patient with steroids can really prevent a worsening of ILD and avoid fatal adverse events, because we have seen in some of these trials some fatal cases of ILD. For instance, in the phase 1 trial of patritumab deruxtecan in breast cancer, there was one case of fatal ILD related to a drug. It's extremely important to diagnose it early and to treat it effectively with steroids. And I don't know, Aakash, if you have some additional tips on how to utilize patritumab deruxtecan and other ADCs in general in the best possible way.
I really like your 5S rule. And I think really the first one being screen. I think we need to do better and know more about the patient selection bit. We've talked a little bit about how right now we don't really know the mechanistic implications and, how patient selection can improve. I think really, as a field, we need to push to potentially have better methods of detection of the mechanism, the target antigen expression, potentially using multi-omic approaches and AI in the future, really to help with patient selection. I think right now in the clinic, really everything you guys said, really being cautious that these drugs, although are sort of the new antibody-based drugs, better tolerated, with all the information we see out there, these still are, as you mentioned, associated with a lot of side effects, which are sort of more chemo-driven and really need to be very cautious as we're using these drugs in the clinic. I think for people like our colleagues in the emergency room and others, as we've sort of started doing with our immunotherapy patients, really, it's very important for other colleagues to be cognizant of what treatments they are on with the, specifically with the ADC, sort of thinking like we think about pneumonitis and colitis with immunotherapy, really thinking about ILD as sort of top of your differential, especially when a patient comes into the emergency room. So with that said, I think this was a fantastic discussion. And I'm really, really thankful to CCO, not just for this, the opportunity to be part of the podcast with these two amazing oncologists, but two of my best friends in the oncology communities. This was really, really fascinating discussion. I really loved it. And I hope our listeners also find it useful and enjoy it as much as we have recording it. Thank you so much.
Let me echo you, Aakash. I also love this discussion. Thank you so much. And thank you to everybody that joined us, listened to us. And thank you, of course, Narjust, also for providing your insights. Any last minute comments?
I'm delighted to be here. I learn for each one of you every second. But I think what I can take home is that Paolo still knows the lyrics to that Bastric Boys song. And second, HER3 is here to stay. We need to learn about it. It's not like it's going to be a later thing. I'm enrolling patients to HER3 alone too myself. It is here to stay. We need to understand these drugs. We need to get familiar with ADCs because they're going nowhere. So it is my pleasure, as the two of you say, and I think it's time to close out here. Thank you.
Thank you very much to our panel of experts, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Unlocking the Power of Novel HER3 Targeting Agents in NSCLC and Breast Cancer, Expert Insights and Considerations for Precision Care, please click on the link in the show notes. As always, thanks for listening.